Dear Chairman, ladies and gentlemen, first of all, I am very thankful to Professor Tambandi and organizing committee members for giving an opportunity to give a lecture in this very important Congress. I also congratulate them for their hard work doing this meeting perfect. I'm very proud of receiving the second Powell-Sarin Lifetime Achievement Award. Thanks to chairman and members of APASL steering committee. I've never forgotten my parents who raised me. Also, I'm grateful to my family who have always supported me and provided a happy life for my success. I really appreciate very much to some of my teachers and friends for their support in my academic career. Mentors are people who volunteer their time, experience, and effort to help others fulfill their potential and achieve their goals. I have two mentors, Professor Zafer Paykoç and Professor Kunio Okuda, in my academic life. Professor Paykoç taught me the art of medicine and principle of clinical gastroenterology. Professor Okuda showed me how to write articles and conduct clinical research during my study at Chiba University for 2.5 years. My research published in American Journal of Röntgenology with his guidance in 1981. We were an excellent team in the first Department of Internal Medicine at Chiba University. Now, I'm going to talk about non-surgical treatment options of hepatocellular carcinoma. This busy slide is my CV. I think everybody knows the progress of hepatocellular carcinoma. Professor Robert Peters and Professor Kunio Okuda edited monography entitled Hepatocellular Carcinoma, published by John Wiley in 1976. This was a milestone in hepatocellular carcinoma. New information has accumulated in the molecular biology of hepatitis viruses and oncogenes and in their potential etiological role in hepatocarcinogenesis, and remarkable progress has been made in the diagnosis and treatment. My lecture in this special session is third speech of mine titled Management of HCC during APASL Congresses. When I talk about the treatment of HCC during APASL Single Topic Congress held in Istanbul in 2009, it was only drugs sorafenib was approved. Together with the recognition of its severity and harmfulness, great progress has been made in HCC treatment for the last 40 years. The outcomes have improved in the past decades with 5-year survival rates from 18 to 40% in the 1980s, rising to 85% 1 year and 70% 5-year survival, regarding with improvements, local regional therapies, and increasing number of liver transplantation. Today, there are many targeted agents, including lenvatinib, regorafenib, nivolumab, cabozantinib, approved for HCC, especially for the last 5 years. The type of treatment for HCC is largely dependent on how advanced the tumors have developed. Thus, tumor staging is a crucial basis for the selection of surgical and non-surgical therapeutic interventions and has a significant impact on therapeutic outcomes. Among the many HCC staging systems that have been developed around the world, the Barcelona Clinic Liver Cancer and APASL HCC staging systems have emerged as the most useful to guide treatment decisions. BCLC staging system takes into account variables related to tumor stage, liver function, physical status, and cancer-related symptoms, and links their these with treatment options and life expectancy. On the basis of BCLC staging system, patients may classify 5 stages. Very early and early ACC have single nodule or 3 nodules less than 3 centimeters in diameter. These patients may benefit from curative therapy. Intermediate ACC has multiple nodules. These patients may benefit from chemoembolization and radioembolization. Advanced and terminal ACC have multiple nodules with portal invasion. These patients may benefit systemic and palliative treatments. New agents may be considered. Masao Mata and members of APASL ACC study group published the guideline on management of ACC in Hepatology International. APASL treatment algorithm of ACC consists of 3 stages and considers parameters of extrahepatic metastasis, childbirth stage, resectability, macrovascular invasion, tumor number, and tumor size. The order of columns corresponds to the decision-making process of treatment in field practice. Standard treatments with high evidence levels and treatment being widely performed in field practice in the Asia-Pacific region are demonstrated. Decisions regarding resectability should be made in a multidisciplinary team. Local ablation is an alternative treatment in resectable patients with less than 3 nodules and in the diameter less than 3 centimeters. Radiofrequency is recommended as the first choice for the local ablation. Transarterial chemoembolization is an alternative treatment with macrovascular invasion, but without extrahepatic metastasis. Treatment conversion from TACE to systemic therapy is recommended for patients in whom is expected to be ineffective. Currently, sorafenib and regorafenib are drugs that have shown clinical benefits in phase 3 studies. Liver transplantation is recommended as a first-line treatment for ACC among childbirth class B and C patients. Among the various local ablation therapies, the most commonly used modalities include percutaneous ethanol injection and radiofrequency ablation, whereas percutaneous acetic acid injection and microwave ablation are less often used. Also, transarterial chemoembolization and transarterial radioembolization are used very often. Radiotherapies like 3D CRT and SBRT recently can be used. Last year, Makary and his colleagues summarized the clinical utility, risks, and benefits of various local regional therapies for hepatocellular carcinoma. Percutaneous ethanol injection is an effective treatment for small ACC. This procedure is simple, convenient, and less costly. You can see one of our applications. 95% alcohol is slowly injected into the tumor mass via a puncture needle previously inserted under the guidance of ultrasound. The high concentration of ethanol infiltrates the tumor tissue where it dehydrates the tumor cells and causes protein degradation and coagulative necrosis of the tumor and surrounding tissues. In this slide, you can see the ablation of 13 centimeter in diameter hepatocellular carcinoma disappeared after PEI application after 3 months. Here is the historical progress of PEI application. We presented our first experience for pay treatment of ACC in 1989. The results of Professor Sheena, who is the most experienced investigator for the pay treatment of hepatocellular carcinoma, were very promising. But recently, pay has been replaced by radiofrequency ablation. Radiofrequency ablation, the heat generated by high-frequency alternating current, is transduced into the tumor tissue through an electrode probe. The transducer heat causes necrosis and scarring in the tumor tissue. Here, the application of RF at the beginning, middle, and at the end of the procedure in one of our patients. When we look at the success rate, 3-year survival, and failures of pay and RF in different studies, RF is better than pay. Among these, 3-year survival is longest in Sheena's study. In this study, Sheena concluded that RF could be locally curative for ACC, resulting in survival for as long as 10 years, and was a safe procedure, and also RF might be a first-line treatment for selected patients with early-stage ACC. The risk of seeding cancer cells along the needle passage is real during percutaneous ablation, but in our experience is very rare. In this slide, you can see the comparison between RF and microwave ablations. Size of ACC is predictive factor for complete ablation, and survival rates are the same in both ablations. There is no significant difference between RF and hepatic resection in various studies. Transcatheter arterial chemoembolization causes tumor necrosis by blocking the tumor blood supply with the emulsion of chemotherapy drugs and lipoidol, while exerting minimal impact on the normal liver. TACE is the first choice for unresectable advanced liver cancer and is one of the preferred therapies for small ACC. Levitt and Lowe showed that 3-year survival following TACE treatment was 26 and 29 months, better than control groups. Especially TACE shows satisfactory results on ACC smaller than 5 centimeters in diameter. In the recent study published by Lee, it was demonstrated that TACE is more efficient and equally tolerant compared with the conventional TACE in patients with ACC. Radioembolization via the hepatic artery using microspheres impregnated with yttrium-90 has been investigated in the treatment of unresectable ACC. When we look at the clinical outcomes of TARE for ACC, in various studies, response rates are almost the same, and survival changes according to prognostic stage. Sorafenib, an oral tyrosine kinase inhibitor that suppresses tumor proliferation and angiogenesis, was shown in large Western placebo-controlled to significantly prolong survival from 7.9 months and 10.7 months in patients with Charles A cirrhosis and advanced, showing in this slide. These findings were confirmed in a second trial conducted in Asia. Sorafenib is recommended for the first-line treatment of advanced stage patients who are not suitable for local regional therapy and who have child pox class A liver function. Recently, there are many other drugs like as regorafenib, nivolumab, lenvatinib, pembrolizumab, cabozantinib, and ramucirumab should be used to bridge patients to transplant or to delay recurrence if possible. Immunotherapies are considered to be a promising approach for ACC patients, even in those refractory to conventional therapies. As you can see in the slide, several clinical trials investigate the role of checkpoint inhibitors and angiogenetic agents as adjuvant therapy. Nevertheless, phase 3 clinical trials of immune checkpoint monotherapies in patients with ACC have failed to show superiority to control groups for overall survival and progression-free survival. Recently, Chen and his colleagues summarized the treatment of ACC in different stages according to modified BCLC. Ablation therapies are performed stages 0 and A, 5-year survival rate of 33 to 60%. TACE and TARE are performed stage B, an overall survival rate of 50%. Systemic drug therapies are applied stage C, having 9 to 14% overall survival. I would like to inform about the influence of COVID-19 to the ACC treatment. Sheena and our colleagues published in article Hepatology International. My conclusion: treatment options for ACC is largely dependent on how advanced the tumors have developed. Tumor staging is a crucial basis for the selection of treatment options and has a significant impact on therapeutic outcomes. PAI can be used as a simple and cheap procedure, but not very effective. RF ablates ACC nodules in small sizes with lower local recurrence rate. TACE is recommended as a first-line treatment of ACC for patients with unresectable, large, and multifocal ACC who do not have vascular invasion or extrahepatic spread. TACE combines with RF or microwave ablation is a better choice because of the specialty of TACE in reducing or preventing blood flow. TARE has been shown in many clinical trials to be safe and effective in the management of unresectable ACC. Sorafenib was demonstrated as significant survival advantage in patients with advanced ACC. Numerous studies have evaluated other novel targeted therapies such as regorafenib, lenvatinib. Immunotherapy has recently become a promising method for inhibiting ACC tumor progression, recurrence, and metastasis. Finally, management of ACC is best performed in a multidisciplinary approach. Thank you very much for your attention.